Dear friends, dear colleagues, welcome to this PCR Spotlight video, which is a part of the series Facing COVID-19 with PCR. My name is Dejan Milasinovic, and I'm an interventional cardiologist from Belgrade, Serbia, and I have the great privilege and pleasure today to be joined by Dr. Azeem Latib from the Montefiore Medical Center, New York, and by Bernhard Reimers from Milan, Italy, Humanitas Research Hospital. So our focus today will be to discuss the roles and the potentials of cardiology teams to help in the care of COVID-19 patients. What we have defined as potential areas of impact between cardiology and COVID-19 are basically three topics, three issues. One is how the infrastructure and organization of cardiology services in more specifically, but also hospital services in general are impacted by this pandemic. Secondly, we will discuss what cardiologists could help in the treatment course of COVID-19 patients. And thirdly, we will discuss the impact, the psychological impact of COVID-19 on cardiology teams. So I would like to start with Azeem, who comes from New York, that has been really badly hit by this pandemic. So how was it in your hospital, Azeem? How did the cardiology services changed in terms of infrastructure and organization?
Hi, Dejan. Thank you for having me. So, as everybody knows, New York really became the epicenter. And New York's a very big city, very dense population. I work in the Bronx. And the Bronx was particularly hard hit. We have the highest prevalence of COVID. So we could see early on the curve that we were going to be really affected by the pandemic. At the height of our COVID pandemic in New York, we had about 2,000 patients in the hospital system and about 500 patients on ventilators. We predicted this would happen early on, so we made a lot of changes in the hospital in order to be able to accommodate this surge of patients. We did things like changing our grand hall, where we usually would give grand rounds. We took all the chairs out and we turned that into an ICU. And then we looked at the cath lab as well, and we knew that there was the potential that we would all, as staff members, be split up and be repurposed around the hospital to manage intensive care patients. So what we decided to do to keep our team together and to contribute to the fight was to create an ICU in the cath lab. So we turned our holding area in the cath lab into a 12-bed ICU. 9 beds were dedicated to COVID patients with a COVID-positive cath lab. And then we had a separate area. We built temporary walls in order to separate the other cath lab, which became our COVID-negative cath lab, and 3 beds for COVID-negative patients who would potentially come in with a STEMI. And this really helped us in order to contribute to the fight, but also to use our team and our skills to the best.
And could you please tell us what happened to the cath lab team? Were you all split between different departments, or did you all stay together?
So our concern was that staff would be repurposed to manage all these new ICUs around the hospital that we were creating, what we almost called sort of informal ICUs, because they weren't traditional ICUs. We were ventilating patients all over the hospital. So we decided we wanted to keep our team together, that in a crisis, you function better when you with people you know and with your own team. And you can face adversity and challenges much better when you're with your team. So in order to keep our team together was one of the reasons we created this ICU, because we manned this ICU with our nurses from the cath lab who all have critical care skills. And so, it was a little bit of a change for them, but they do have a lot of important skills. Our cardiovascular techs helped in patient care and in management, in helping to prone patients, in helping to manage the ventilators and clean as well. Our fellows became our junior intensivists because they're so good at internal medicine. And we really kept the whole team together looking after these patients.
So if I can summarize, basically what you did at the peak of the pandemic, you turned your cath lab into an ICU and you helped caring intensively for these critically ill patients. Now, maybe a final question. How did you organize? Was there a supervision for you cardiologists caring in the ICU for these patients?
clearly, all of us on this are interventional cardiologists, and many of us have not managed a ventilated patient for some time, and it was quite intimidating. We do have good skills, though, right? Because we all know how to put in central lines, arterial lines, and I think as interventional cardiologists, we're very good learners. We're always reading, we're always trying to get better at what we do. So what happened in our hospital was the critical care team became really the center of the hospital. They created a central command center where they had, links, live links to all the different ICUs around the hospital, where they could monitor patients remotely. At this command center, you could call day or night. There was always a critical care specialist there, and you could get an opinion on your patient virtually. They could log in, see what's happening with your patient, see the blood gas, and give you advice on how to manage the patient. If they needed to come, they would send a team, and they would come. They also created very clear protocols for us to follow for each of the different problems we would face, from how to anticoagulate patients, to how to use high flow nasal cannula, to what therapies we should be instituting. And then the one thing we really liked was they created very simple YouTube videos on things such as how to use a ventilator, and particularly the ventilator we had in our hospital. So it was very clearly done which buttons you pressed, how you change ventilator settings, and that really made it easier for us to feel more comfortable in managing these sick patients.
Thank you, Azeem. This was very helpful. And we heard that in your hospital, interventional cardiologists have been involved critically in the intensive care units and really caring for these critically ill patients. Bernhard, how was the situation in your hospital in Milan? In what ways were interventional cardiologists there involved in the care of COVID-19 patients?
Hi, Dejan. Hi, Azeem. Thank you for having me at PCR. We didn't do intensive care medicine. That was different from New York. Actually, from the cardiology department, I think 60% of the doctors went into the COVID wards, but not the intensive care wards. And from our interventional list, we are 6. 2 went into the COVID wards. I had to organize a little bit the stuff, and 2 did not go into the COVID ward, and 1 was had COVID, so he was not there, couldn't help us. And I think that reflects a little bit the cardiology department. 60% in the COVID wards, 40 or 30 just kept up interventional cardiology, but also general cardiology services. And 10% were at home in quarantine or ill.
Thank you. So we've talked about how the organization changed. And Bernhard, how was it actually that the cardiologists were involved, in fact, in the care of these patients? What did you as cardiologists do to treat these patients?
So luckily, our hospital did not collapse. Our sister hospital in Bergamo, there was another hospital in Bergamo and one in Brescia, they really did collapse because they had 220 patients in 4 days, and that were surgical hospitals. So it was completely, they were not prepared, and there were queues of the ambulances in front of the hospital waiting to find a bed. We had the fortune or the luxury that we were always 1 week ahead of the tsunami. So at the end, we changed out of 15 wards, 8 became COVID wards, but 1 was filled up and already the next was set up. So it was interestingly quite smooth. Doctors for the wards, it was mixed. We had 1 cardiologist became responsible of a COVID ward. But in every COVID ward, there was a cardiologist. Of course, there was an internal doctor. There were surgeons, and what doctors we had in our hospital. And so the doctors, the cardiologists were needed, definitely to look at the EKGs. All the drugs we gave, the anti-malaria drugs, the viral drugs, and also the antibiotics can prolong the QT, and we had some ventricular fibrillations that we had to address. So we looked at this and suspended the drugs if the QT became too long. And that was, of course, the cardiologist of the ward who had to look after this. We did many heart echoes because of the troponin leak, but again, we didn't find so many dramatic myocarditis or also pulmonary embolism on the right heart that we were able to diagnose with the echo. So we have the data, but I don't know how much it did impact the care of our patients.
Thank you, Bernhard. So you mentioned the troponin leaks, and we know from what is available so far of the literature that in approximately 10% of these patients, you really have a significant troponin leaks, and there is also some data linking these troponin leaks to increased mortality. So Azeem, how was it in your experience? What did you do with the troponin leaks? Was there an institutional algorithm, or what actually did you as interventional cardiologists do in this case?
Yeah, it's a great question. We were a little bit fortunate in being 2 to 3 weeks after Italy. We learned a lot from our colleagues in Italy, what they shared with us and what they published. So we knew that troponin was a bystander. It was a biomarker, along with many other biomarkers in COVID that could be elevated. So we early on had an institutional protocol that on all admitted patients, we would do troponin. Besides looking for lymphopenia, we would also do troponin, we would do CRP, we would do D-dimers, and because we knew these markers all were elevated often together in the sickest patients. We realized that troponin could be a marker just of severity of COVID-19 disease, but also that it could be a marker of cardiac disease. So our algorithm was, if you had elevated biomarkers, we looked at the ECG then remotely. If ECG changes, we then said this was related to just the COVID and the severity of the COVID. If there were ECG changes, we would then investigate further by doing a bedside echo. And we started using these mobile echoes that can be attached to a phone or to an iPad, such as a Lumify or Butterfly. And that was just easier to get into the patient's room that was COVID without bringing a big machine in that could be contaminated. If the echo then was completely normal, it stopped there. If there was regional wall motion abnormality on the echo, we would work the patient up further. Could this be a acute coronary syndrome? If it was global, we would then involve our heart failure team, and we would go as far in some of these patients as doing a myocardial biopsy.
Were there any other interventional cardiology skills that are specifically employed in these patients?
Yeah, absolutely. So, as interventional cardiologists, we were called to do a number of other procedures. So I mentioned the RV biopsies in some of these patients with myocarditis. We also, some of these patients were, who had pulmonary disease as well as cardiac disease, we would, help perform right heart caths to try and understand the hemodynamics. We also saw a number of cases of myopericarditis or pericarditis with pericardial effusions. And because these patients were sick and with COVID, we were called to do some bedside pericardiocentesis that was echo-guided in the ICU. And then probably the last part where we were sometimes called was, as you know, there is a increased hypercoagulability with COVID. And so a number of patients did get pulmonary emboli. So we would sometimes be called to help with a differential diagnosis or to exclude a pulmonary embolus.
Thank you very much. So if we can wrap it up, what we have said so far, we have learned so far from both of you is that the central issue here is that we have a cardiology team involved that can help in many ways to treat COVID-19 patients. So Bernhard, given that cardiology teams involve not only interventional cardiologists, but also fellows and nurses, how was the impact of this pandemic on the cardiology teams in your center?
Obviously, a real big impact. I think the most important thing that we learned, it's important to be a doctor, not necessarily a cardiologist or interventional cardiologist, because we were called to be doctors for a pandemic, and I think it's good. And as Azeem said, the fellows were probably the best doctors because they were out of medical school, not 20 or 30 years like I am, but they were fresh from there, so they knew some more. Impact, our team got pretty much divided. So we didn't work as a team to care from them. So we were really split up. But this was a policy of the hospital to have a cardiologist on every COVID ward. Now all come back. It's not too easy to get together again. Definitely, we feel more closer related, and I feel a lot of proudness because I'm really proud because the team, the cardiologists in the hospital were very much appreciated by the other doctors, by the other responsibles of the COVID ward. So probably my team did a good work. So the cardiologist still has some possibility to work also in a pandemic. We have to stick together. We have to stay alert because there definitely will be some trauma because we haven't been used to so many deaths and so big problems. But I think doctors, nurses, they all went through a tough time, and probably we grow up a little bit. And I'm very happy to keep this team together, but we have to continue. The exit strategy, also psychological exit strategy, has to be nearly as careful as the entry strategy.
Azeem, given the very high numbers that you have been confronted with in your hospital and the many critically ill patients that you helped care for, what was the psychological impact on the different members of cardiology team in your hospital?
We really, in the height of the pandemic and the surge here in New York, there were patients dying every day. In our hospital, when there's a cardiac arrest or someone's coding because they call for the code team to over the hospital PA system to come in to a specific ward. And there were days we would hear this all the time. So the number of deaths, the hard work, the working with an infectious disease where you risk being infected as a healthcare worker or bringing the infection home, seeing so many people dying or seeing your colleagues getting sick and going home had a huge negative impact on us. What really helped us all get through it were a couple of things. The one was information. And I think that's really important, and an important message is to keep your teams informed as much as possible. They need to know what's going on in the hospital. They need to know what's going on in your team. They need to know that there's a plan of what's going on day to day. That helped. Also creating a sense of optimism. So, every time we discharged a patient from our unit, everybody would be standing there and applauding the patient because we knew the fight they did to get off the ventilator. When patients were extubated in our hospital, we had something called the Happy Code. And we played the song by Alicia Keys called Empire State of Mind. And when it played, it created just this joyness in the hospital because we knew we were overcoming the hardships. And then thirdly, our psychiatry department, it was difficult to repurpose psychiatrists and put them in COVID units. But what they did was they provided a service, a counseling service to all our staff that was 24/7. And that really helped us get through this. The last thing I would probably say, because it would be amiss for me not to say it, is how appreciative I was of all the ancillary staff that we sometimes forget in the cath lab. And particularly our nurses, our techs, the admin staff, everybody pitched in to help us get over this pandemic.
Thank you very much. Thank you both. Thank you, Azeem. Thank you, Bernhard, for sharing with us these valuable experiences. And I hope that this will help our colleagues around the world who are still confronting large numbers of COVID patients coming in to the hospitals. Just to wrap it up, I think that maybe one of the take-home messages is that we need to be very adaptive. We need to adapt our organizational and infrastructural services to meet the high demand that COVID-19 could pose on us, and we need to adapt our skills to serve the COVID patients as cardiologists as best as we can. And lastly, but not least, we need to take care of the whole cardiology team. We need to provide also psychological support for our team members. Thank you once again for everybody for joining us, and I hope that you could learn a lot from our two colleagues, and I hope that you will also see other videos from the series Facing COVID-19 with PCR. Thank you very much.